It's a pleasure to welcome everyone. I would like to congratulate the foundation. As you can see, we have a very rich program today. And I was particularly happy to see this program because, as you will see at the end of my presentation, multidisciplinary approach is very important in patient care. It's not only specialists, clinicians, but other professions, health professions are important. This is a special conference where patients, clinicians, and other health professionals are all present. There are very few such conferences, so I would like to congratulate with all my heart for the organizers, and the last one 2 years ago was very successful, and I'm sure this one will be equally very successful. You can also already see my presentation. I think all of you know this disease very well who are present. I can see a lot of CMT patients. It doesn't work. I have a technical problem with. Okay, thank you. It works now. As for the disease, it's the disease of peripheral nerves. There can be two types of problems, either the axon. You have the cell body and you have the axon here. It's either the axon or the myelin sheath, which helps the conduction of the nerve fiber. And the disease of the myelin sheath can equally lead to a damage to the same extent as if the axon is damaged. So we will see the difference between cases when it's the axon and other cases when it's the myelin sheath that's damaged. The disease is named after specialists that first described the disease. And if you look at the meaning, hereditary means HMSN means hereditary motor and sensory neuropathy, which we abbreviate as HMSN, but we mostly use the abbreviation CMT, which we all use. You can see on this slide that there are other neuropathies that can overlap, where vegetative nerves can be affected. It's not extremely rare, but it's a classical rare disease. Depending on the onset and the speed of progressing, we have different forms. We have a slowly progressing form with onset in the teenage years. We have the early onset form, where we have muscle tone problems, very early problems with the toes, and we have the late onset form above 40 years of age. The symptoms are similar. The legs become very slim and the toes are affected. The foot symptoms are very characteristic. It's the earliest symptom, except for the very early onset forms. You can see different feet. First, you can see on picture A, the anatomy is normal. On picture B, you can see the high arch. We usually ask whether it's usual in the family. On C, you can see the toes are rotating and the whole foot is rotating inwards. Why is that? Certain small muscles atrophy and cannot ensure the statics for the foot. And the deformity becomes worse, and it can distort the bones, and the Achilles tendon cannot be straightened, and the walking becomes more and more difficult. obviously. The first most important examination is ENG. It's an electric examine to make the difference between the myelinizing and axonal form. The demyelinizing form is where the myelin sheath is affected, and it's not important. It's important to make the difference for the later genetic exams. The difference is made based on the conduction's velocity. If the conduction's velocity is small, it's demyelinizing. If it's above a certain threshold, it's axonal. So you should not be afraid of the ENG. It's important. The next thing to make the difference is between hereditary or non-hereditary disease. In cases of late onset diseases above 40 years of age, many diseases are acquired. And on this diagram, you can see how we are trying to mean the difference. We are trying to exclude toxic damages such as alcohol, diabetes, which are the most frequent, but there are other toxic damages, or infections like borreliosis and other infections, or inflammations due to autoimmune diseases. And the treatment is is entirely different. Other strategies must be followed. And the patient can help a lot by telling whether there has been a similar case in the family, what are the symptoms, because his symptoms may not be very severe, but there might have been other family members with the same foot presentation. And as for genetics, you have autosomal genetic disease with one chromosomal defect, which can be sufficient for the disease. You can see that we have a lot of autosomal dominant forms in CMT. Autosomal recessive means that you have to have both alleles affected, and you have the disease linked to the X chromosome. We have genes on this chromosome as well, which can lead to CMT. So this is how we, these are the categories we use: autosomal dominant demyelinizing CMT1, AD axonal CMT2, AR CMT4, and X-linked CMTX. You can see that there are that certain genes are linked to certain types, but there are overlaps. So it's not always easy to make the difference. And you have a list here. CMT1 is the myelinizing form, and here you have the axonal forms and the intermediary forms. But you can see that 50–80% of CMT genes are associated with this group of disease. There are quite relatively few genes in these groups, so it can be diagnosed much easily. In CMT group, you have more genes, but it's only 10–15% of the cases. And you have CMT4 and X. As for CMTX, it's important because we usually say that only the boys are affected, but this is an exception because daughters, girls can also be affected with the defect of this gene. So we usually start with the examination of this gene. How does this work? We usually ask questions from the family. We build a family tree. We ask them whether there have been marriages between relatives. And for example, there's a specific mutation which is quite frequent among the Roma population. So we make the difference between acquired and hereditary causes. When, if we believe it's hereditary, we launch the examination, and we have peripheral myelin protein, and about 60–70% of CMTs is due to this problem, PMP22, and we usually start the diagnosis with this one. If it's a boy dominance, I start the examination with 32. So the family tree and ENG results help guide me where to start the examination. If it does not help, we run a panel examination which looks at several genes at the same time. As for the frequency, you can see PMP22 and GMB or connexin 22. PMP22 can be associated to a defect where there are less or more genes than necessary. If it's less, you have a pressure neuropathy. If no nerves are under pressure, you have no symptoms, but if you cross your legs, for example, you might have the symptoms. And when you uncross your legs, normally it goes away, but in the case of this problem, it does not go away, so you need to avoid these positions where nerves can be pressured. In axonal forms, well, as for the diagnostic of axonal forms, it's not very easy because many more genes can be implicated. And you can see on this diagram, if you look at all the CMT patients, PMP22 is involved in more than 50%, 21% is associated with deletion, gene deletion. It's already almost 2/3 of the diseases, and all the others are very, very rare. They are associated with other genes. So you can cover a huge percentage of patients with a relatively small panel. Well, what about the success of diagnostics? In the case of demyelinization, it's 60–70%. In other cases, it's not. It's under 50%. Why is that? Even though we run a whole exome genetic panel, if the gene defect is not on the coding region, we do not have information about that, and we are developing new technologies which will lead to diagnostic success. So in case you don't have a genetic diagnostic right now, do not lose heart. New technologies will appear. In many cases, other genes can lead to other diseases, which also lead to muscle weakness, such as SMA, ALS, which means these genes can lead to several types of diseases. You have special forms like the daughter of Rita, who has the mutation of TRPV4, of which we know relatively little, and an important communication was published in 2024 where they looked at various muscle weaknesses, whether the upper or lower limb weakness is dominant. They looked at the onset of the disease. For some people, it's above 30 or 40 years of age, and whether the upper limb or the lower limb is affected. It's interesting that in this case it's usually the upper limb, and you have the comparison of between various mutation. You have certain mutations where progress is very slow, and there are other mutations where progression is more explicit. It depends on the type of the genetic defect. And we had a questionnaire which symptoms were the most bothersome for patients, and they mentioned first the walking and also the breathing difficulties. Breathing muscles, vocal cords, speech can be affected, but it's different depending on various types of presentations. What about treatment? Unfortunately, there's no causal therapy for CMT patients right now, but it's very important to go to receive continuous care. Multidisciplinary care must be provided. Quality of life is very important, and I think rehabilitation, physiotherapy, the right orthopedic assistive devices, orthopedic surgery at the right time, pain management are very important, and different health professionals must work together. Ergotherapy, occupational therapy is very important and helps quality of life, and psychological assistance is also important. If you accept your disease, you learn how to live with it, you can have a good quality of life. Many of our patients have this disease since childhood, and they found families, they work, and they live a happy life. It's important to know what to avoid. We must keep our weight. We must not get obese. It's difficult because mobility limitations might lead to less movement, but if you cannot move on the ground, you can go into the water, and we must avoid toxic drugs. The disease is more than enough. We must not weaken our nerves with toxic substances, and you have a list of drugs that you must avoid that are detrimental to peripheral nerves. And this is what you need to avoid living with CMT. And I've mentioned I have some news as for therapies. We have two clinical studies underway right now. Synapse CMT is a phase 2 clinical examination where both CMT1 and CMT2 patients receive therapy. It's a relatively short period of treatment. They look at walking distance and the time of getting up and getting to walk. This therapy influences the Claudich channel, as I've mentioned. Even though it's a peripheral nerve disease, they are trying to improve life quality by improving muscle strength, stabilizing membrane potential. This overexcitement is reduced. This is early phase study, and we have a phase 3 study as well, which means that this is the last phase of clinical examination. It is baclofen, a drug called baclofen, which reduces, relaxes muscles. For CMT1A patients, it's a new therapy. It would be helpful for many CMT1A patients. 350 patients took part in the examinations. The research has finished. Evaluation is underway. The improvement was not significant, which is bad news, but they are also looking at subgroups, and under BMI of the, 25, so without obesity, the improvement was significant. And we have platform for development, such as the CMTA preclinical testing network, which is aimed at retesting already known molecules with the hope of finding molecules that help the function of peripheral nerves. It's a very modern platform to speed up development. And this is my last slide. Genetic examination is very important. It's very important to make the difference between the myelinating and axonal forms, because it will guide us in choosing our first genetic test. Some patients have CIDP chronic forms with autoimmune disease, and they might have a hereditary form. The differentiating between the two types is not always easy, and in many cases, new generation sequencing offers us possibilities. We must use them, and sometimes we have to use a whole exon test or panel, and we must follow the patients and learn about the natural progress of the disease. And there are a lot of research focusing on CMT right now. Thank you very much for your attention.